So, let's look at working on the hand. So the things that we could have in the hand, we could have trigger finger, de Quervain's, we could have carpal tunnel syndrome. Let's just stick with those ones just for now. When you're working on this area, there's a lot of nerve innervation. We have to be very sensitive with our hands, that we use them for all sorts of things. So we've got a lot of nerve endings. This can be very, very painful. And when you're working, say, for example, around the median nerve on these peripheral nerves, I don't think we can just jump straight in with our RO40. Certainly we wouldn't go anywhere near this with our deep impact gold applicator. Instead, we would use, to begin with, the Atlas applicator. So if you were going to work on carpal tunnel syndrome, you'd get some gel onto the forearm as well, and we could, let's just get ourselves sorted here so we're not on the V-actor. Get back to channel 1. I'm quite happy with 2 bar pressure with this, not a problem at all. And hertz wise, I think 12 is going to work absolutely fine. So we start off on the fleshy area, as we said before. We're going to work up and down the forearm. How's that feel? Barely noticeable. We're still getting radial pressure waves into there. As we go over the median nerve, we're definitely working over that carpal tunnel. We're definitely getting, albeit some superficial depth, but we're also doing a treatment the patient can withstand. And Professor Knobloch uses this applicator on all of his hand patients. So I was talking to him last night. We did an interview. The interview's now up on paulhobrough.com if you want to view it. And we talk about hand therapy. We talk about scaphoid fractures. We talk about the carpal tunnel. We talk about trigger finger. And of course, de Quervain's as well. And all of these can be treated with this Atlas applicator initially, and it's very, very effective at getting your patient on board. Because it's so sensitive and so superficial, you'll be doing a very, very good treatment with this. And we can bring the bar pressure. How's that?
3 or 4.
So I've got the bar pressure up to 4 now, and we're still at a 3 or 4 on the pain scale. Even coming across into the trigger finger, where we know it can be very tender over bone, we can do a really, really good treatment over de Quervain's. We're getting a great deal of beneficial treatment into the area, which is not just the hyperstimulation anaesthesia. This is the best way to treat. And if you use this as a warm-up before you brought in your RO40, or even if you've got one, your focus device, which would be my next treatment over here, then you can do a really good job over treatments such as trigger finger, such as carpal tunnel, scaphoid fractures. Did you know that 25 years ago, one of the biggest studies was done on scaphoid fractures, albeit using focus shockwave because radial wasn't around then, but they had something in the region of 154 patients went through with significant results. That's 25 years ago. So, of course, we're going to be feeling that the use of shockwave for bone fracture remodelling and stuff like this and assisting with delayed non-unions is absolutely something we should be looking at with this. Now, are we going to get enough depth with the Atlas applicator? Well, I would possibly argue not, but in terms of the start point of the treatment, if you're going to go to an advanced level where you can spend more than just your 2,500 shots, the Atlas is a great start point. I wouldn't really go for the V-actor except for in the forearms at this point, but I would use the Atlas applicator here. Now once we've done that, remember that I said to you before, if you're going to work in an advanced way, you cannot just sit with just one applicator on all the time. So we're going to go for our RO40. Now we know that over bone this is going to be tender. I mean, my wife's sat here, she knows this, but I wouldn't necessarily be telling this to people. So I'm going to have to bring the bar pressure right the way down, 1.4, and we're going to take the hertz all the way up to 21. And what we're going to do, we're going to test the water, see how this is going. So on the forearm first, remember, go to a fleshy point, up and down the arm, and that's already a 4 out of 10. We could come onto the scaphoid, 7. We could go over the carpal tunnel, 8. So you can straight away see that even on our highest hertz and our lowest bar pressure, it's almost untenable for the person. So how are we going to manage to do this if we don't have something like the Atlas applicator, or we're not able to move onto the focus shockwave? And when we're dealing with some of these hand and peripheral nerve issues, I think that really you do need to be looking at how you're going to do an effective treatment if it's just so painful. And this is someone that doesn't have a condition. So using these and being able to manoeuvre around. Now, if you don't have the Atlas applicator, we can take this one off and you can actually attach the plastic one used normally for the face. Yeah, it's the plastic one. And we should therefore be able to move up a notch perhaps on the Atlas. So how does that feel? 3. Over here? 3. So, we're going to increase our bar pressure quite significantly. And we're going to drop our hertz. How's that feeling? 4. And over here? 4. So we got to a 4 out of 10. I'm just going to take the bar pressure up again. We're up at 3 bar pressure, and we're now down at 12 hertz with this plastic one. So we know we don't have anything like the depth, but we can start to treat Atlas and then using this plastic applicator, and we're actually getting an effective treatment. We're getting our bar pressure up, and we're working on the areas that we need to. The quervins, trigger finger, over the carpal tunnel, working all the way through the fleshy part of the upper arm. And eventually, as the session goes on, or even into the second or third session, I would suggest that we'd be able to move up to our RO40, our standard applicator, as the patient starts to get better and they start to get more used to it. But the way you build up to that is so important, because if I'd just gone straight in with the standard applicator, trying to deal with any of these hand conditions, I can say with absolute certainty that we would have found the patient, notwithstanding it, probably not coming back, therefore they're not getting an effective treatment from Shockwave. So you have to be in a position where you can manoeuvre these applicators around significantly. But we are also compromising depth. The higher the hertz we go, we slightly alter the amount of depth that we can get into the tissues. So how superficial is this median nerve in here? Well, it's very superficial, but we still need some depth. We still need to get beyond the skin. How superficial is our dequervins? Well, very superficial. Trigger finger, very superficial. So we're having an effective treatment. What happens now if we think about the elbow, where we do have peripheral nerves that are going to affect the pain, but we've also got bony tissue, just like we do in the carpal bones here. And trying to use an RO40 over bony tissue is very, very difficult. So if we just pull that forwards a little bit, just bring your chair forward. Just trying hard to keep everything in the camera there for you. Golfer's elbow is probably one of the more painful treatments that you would give to somebody. Very few people that get golfer's elbow actually play golf. Been doing too many webinars, so I'm running out of this. So we could go with this plastic end here. I don't have any problem with that. And pain level wise, it's only about a 3 out of 10. So, bear in mind that I can use a 3 bar pressure to warm this patient up to get the hyperstimulation anaesthesia. Well, that's really good. What happens if on the same settings we move to the Atlas? Same settings. So 4 or 5, so we're getting a little bit more depth. We start to search around for where the most painful spot is. Obviously we find it on the common origin, and we can warm that up using the Atlas, no problem. How's that? 5, tell me when it drops. You can literally determine your warm-up based upon the patient feedback. So as we start to do this, usually speaking, pain's going to start to drop more to a 4, then to a 3, then you know that you're kind of okay to move on to the next applicator. Right, so we've got confirmation it's dropped to a 3. Move to our RO40. Now, what you can't do, as hopefully we've laboured the point, is just jump straight in at the same settings. So we're going to move our settings across. Come on to here, we're going to drop our bar pressure right the way down to 1.4. We're going to bring our hertz right back up again. On the basis that we're changing applicators, so we're now getting more depth. Let's see how this feels.
3 or 4?
3 or 4, not too dissimilar. So what do we want to do? We want to get increased bar pressure first of all. How's that? So here I am at 2.6 bar pressure on a tennis elbow using the RO40, and albeit I'm at 21 hertz, but what's the pain like?
4.
Manageable 4. As we start to drop the hertz, tell me what happens.
Slightly rotated.
Still not at 5.
I'd say it's 5 now.
So I've got down to 15 hertz. I'm on 2.6 bar pressure, and I'm using the RO40. This, before we started doing this change in the applicators and moving through them, it might have been the 3rd or 4th session before we achieved this. So you can see we have to work with the immediate pain response, and you have to be using at least 2 applicators per treatment. I don't think you can reliably think you're going to do this for any less. So we can look at hand and elbow, and we can look versus foot and ankle. They're very, very different in the way you need to treat them. Likewise, if you're doing a high hamstring, it's very, very different in terms of how you might use the gold applicator for something like that. Similarly, around the shoulder, if we just finish off by looking at the shoulder, just bring your chair around and face this way. I'll try and get everything in the camera. There we go. So hopefully that's all in play there. So we're working on the shoulder. It's relatively straightforward to think about us working into, let's say, the bicep tendon, where we've got a bit of muscle tissue and stuff coming across from the rotator cuff. It's fairly understandable that we can use something like a gold applicator if we're trying to work on frozen shoulder. But what about working on the AC joint, where it's a bony joint and it's very, very tender, and it's going to be very difficult for this person to deal with? I wouldn't even consider starting with the RO40. I would come in, grab something like the plastic end or the Atlas, place this with some gel, and we go straight over the AC joint. What have we got? We've got 2.6 bar and 15 hertz. I think that'll be fine. How's that?
3.
So that's a 3 out of 10. How's that?
3.5, 4.
And now?
4.
So we're 4 out of 10, but I've got 5 bar pressure going through this AC joint. I could even drop the hertz a little bit. We're at 5 yet? So on 13 hertz, but 5 bar pressure working into the AC joint. If I were to move this round to the long head of biceps, how's that?
5, 6, 6, 7, 7.
That's actually more painful. And what about through the posterior joint? You get a chance to see
No,
it.
it was less though.
Fine, we can start that again.
3.
So on a 3 on the back of the shoulder. So for Nicola, I would need to use this on a long head of biceps. I thought the pain might have dropped a little bit, but on the long head of biceps, perhaps we use this. By contrast, for those of you who don't have these end pieces, bear in mind that your goal is to try and get the highest bar pressure you can, but still something the patient can withstand. So let's get the bar pressure right down, and let's get our hertz all the way up to 21. And let's see what happens now. We work in the back there. How's that?
3.
So that's a little bit higher than it was when we were using the Atlas on 5 bar pressure. You come into here
4, 5.
and over the AC joint.
3 then. 7 or 8.
So when you're over bone, it's almost impossible, even at the highest frequency and the lowest bar pressure, to work over that AC joint without the person finding it difficult. So you end up moving off into a slightly more tissue-laden area. Still, because this is the light bulb treatment, we're still getting some into the AC joint. But we're having to kind of manoeuvre around it, which isn't ideal. We want to be directly over the joint. We can, I believe, easily adapt these to get over the long head of bicep. So I'm sure Rich will be telling me to stop soon. But let's just see what bar pressure we can get up to. How's that?
About 4, 5.
Okay, and we bring the hertz down, tell me when it starts to go up.
Yeah, it's out, slightly out.
Okay, so I can get this 7.
6.
I can get this to 16 hertz on 3 bar pressure, and we're only at a 6 out of 10. So by doing the leg work beforehand, and by you can finish with you now if that's all right. Thank you, Nicola. By doing the leg work and thinking about your patient and how you want to treat them, you have to use your strong anatomy and physiology to make sure that you know what tissue you're trying to get to, you know what depth it is you're trying to get to, and therefore you can start to work around the different applicators on the end of your radial pressure wave. There is less difficulty when you're using the focus shockwave, and next week we're going to be talking in detail about focus shockwave. But for now, because I would say 98% of the population in the UK just have a radial pressure device, you've got to think about how you're going to get to those depths, how you're going to work this in so that your patient isn't going to run away scared, given that most of the things they've heard about shockwave therapy is that it's really very, very painful, and they come in scared. So their sensation level is at the height similar to if you're walking along gravel and suddenly you've got a frozen pond in front of you that you want to cross, and you start to walk very, very gingerly over the ice, and you get much, much more sensory information into the brain about that, so that they walk in a bit like they're walking on ice, if you can work with that analogy. So they're feeling more, they're sensing more, and you've already, just by the way you've interacted with them, you've made it harder to reach that nice high bar pressure. So please, going away from this, think about how you might treat different elements within the body. So we've spoken a bit more about peripheral nerves, which is quite an advanced level technique. We've also taken you about how you might work interacting with the different applicators, even just doing something that's fairly straightforward like an Achilles tendinopathy. So work on the trigger points, work on the soft tissue. But for those difficult patients that won't just say crack on, do whatever you need to, that are quite sensitive, and we're seeing more and more of them as shockwave starts to become more known, the leading piece of advertising is that, yeah, it gets you better quicker, but it's really painful. And we need to start changing that perception with the way we treat by using this advanced skill set to use the hertz to much better advantage, but to also use the different applicators. We did a really good video yesterday, I mentioned it earlier, myself and Karsten, all about different techniques and different treatments that you can use for shockwave. And we got into lymphedema, we got into hands, we got into aesthetics, and that's on paulhobrough.com. And in a second, there's going to be a little QR code coming up. If you just put your phone camera on that and take a picture of it, you'll be able to go straight to the site where that's it. So thank you very much for listening. Hopefully, we've generated a few questions, and so Richard might be in a position to help me out with those, or I might try and read them myself.
That's okay, I can read them to you. So Ian asked one that would fit in with what you've just been talking about. So when you're using a course of shockwave combined with progressive loading, do you tell the client to completely rest from the aggravators?
Right, so it's very good and interesting question, so thanks for that. So appropriate loading on a tendon, for example, we know is a large part of the treatment process. We're using shockwave and appropriate loading because we know from the science that if you just load or just use shockwave, they've got fairly similar benefits. If you load and use Shockwave, you end up with a much better outcome. So we need the patient to load, but we've also, in bringing this hyperstimulation anaesthesia in, they are more likely to go and do aggravating factors, because maybe for only 2 hours, maybe for 2 days, you've reduced their pain. So we have to be really, really prescriptive about what they do. So we want them to do their appropriate loading. Things that were aggravating before, we want them to step away from until such time as we feel happy as a clinician that they trickle those back in again. But bear in mind that they might go and try these things, think they're better because you've numbed the tissue for a short period of time. That's where the downtime of 2 days you might have read about in the literature comes from. I think 40% of their normal training load is appropriate for a day or two afterwards. But don't forget, in Germany in the Bundesliga, equivalent of our Premiership, they're using Shockwave literally at half time or before the game. So it's not a 2-day down period because they're going to do anything nasty to their tendon unless they just don't feel the stimulus. Hopefully that answers your question.
Great, lovely. And another one from Dan. What would be the difference in treatment effectiveness if you applied the applicator with the muscle and the muscle tendon in a stretched state?
So I like to treat the tendon in a slight stretch state anyway, because it's my belief, it's not shared by everybody, it's my belief that if you've got a tendon and you're trying to put pressure into that tendon, you're trying to put an energy into the tendon, Newton's third law suggests that you get an equal and opposite reaction. Yeah. So if that tendon's bouncing around all over the place, then how much energy are we actually getting into it if the tissue is able to move away from us? We want all of the energy to go in. So by putting the tendon on an element of stretch, I think is really good, and I think it improves the treatment outcome, although I have zero science to prove that to you. In terms of putting a muscle on a stretch, I think that you, in terms of the way in which you work with muscle tissue, I don't think it needs to be on a stretch. I think your pressure to take up any slack in the tissues is important, and if you can't do that effectively, then I think you would apply a little bit of stretch. But there isn't a scientific study, unless Cliff's going to come up with one in his talk shortly, that I'm aware of, that changes the efficacy by having it on a stretch or not. It's just my personal preference.
Okay, thank you very much, Paul. I think we'll have to call it a day there from Paul. Thank you very much. I have noted down the other questions that have been asked, and I will pass them over to you. So you're getting an email after me.
And we'll just pop that QR code on at some point, Richard, as promised.
I'll do that now. 2 seconds.
Thanks, everyone. Enjoy the rest of your conference.
Sorry folks, just getting lost on my computer screen now. Okay, so this QR code for Paul's site is just here, so I will include this on the email that goes out as well afterwards, but if you've got a phone to hand, then just